Hi, this is Byron Freemeyer. I'm chair of the Emergency Medicine Quality Improvement Committee, and I'd like to talk to you today a little bit about a project we'll be doing in the Baptist Health System starting at North Central Baptist, dealing with parenteral opioid risk assessment and monitoring. The goal of this is to provide safe opiate treatment for our patients and prevent oversedation through use of a screening tool and then monitoring parameters for these patients. Currently, we have no specific screening or guidance for monitoring for the nurses. So why are we doing this? Well, there have been near misses and deaths, not only in our hospital, but across the country related to opiate-induced oversedation. So for the safety of our patients, and also it's a joint commission requirement that we now begin to assess our patients for this risk and then monitor them. So the first step for this project will be to assess all patients who receive parenteral opiates for risk for oversedation. We came up with the acronym DOSE less. The D standing for patients who are on multiple drugs to begin with, which sedate them. Patients for the O stands for over 65 or obese. S stands for patients with sleep apnea or that have snoring. E is for end-stage liver disease. This could also be end-stage kidney disease. The L is lung disease. E is end-stage kidney disease. The S is sick. That would be patients with chronic debilitating medical conditions such as multiple sclerosis, advanced rheumatoid arthritis, etc. And then the S would be saturation, for saturation of oxygen. Patients that are already below 93% on room air are at higher risk. Now the nursing staff have requested that the physician sign this prior to the patient receiving the parenteral opiates. However, we should be able to work with the nurses to ask these simple questions, and then we would sign it prior to the patient getting the opiates. After the patient has received the opiate, they will have a monitoring documented, which includes the Parenteral scale, which we'll get into in a minute, the oxygenation, the respiratory rate, and the adequacy of respirations. Based on the peak blood levels of these medicines, morphine will be assessed at 30 minutes and then at discharge or transition of care, like if they're admitted to the hospital. Hydromorphone will have an assessment at 30 minutes and 60 minutes and at discharge or transition of care. And fentanyl will have an assessment at 5 minutes and at discharge. For admitted patients, the 60-minute assessment for hydromorphone can be done on the floor, and the inpatient nurses are being trained in the monitoring requirements. So the minimum observation period for parenteral morphine is 30 minutes, and the minimal observation time for parenteral hydromorphone is 60 minutes. So patients should not be discharged home prior to 30 minutes for morphine and prior to 60 minutes for hydromorphone. So what does the monitoring of these patients include? Well, the first step is the POS, or the Parenteral Opiate-Induced Sedation Scale. This is a scale of how sedated the patient is after receiving the opiates. The acceptable range can be divided by one simple question. Can the patient stay awake and talk to me after asking them a question? So if the patient's asleep, if I wake them up, do they stay talking to me or don't they? If the patient can't stay awake and talk to you, then they have a level of 3 or 4 on this scale, which is unacceptable. In addition to the POS, the patient should have an oxygen saturation equal to or greater than 93% at baseline, and at reassessment, the respiratory rate should be 12 or greater. And they should have adequate respirations. They shouldn't be snoring or having periods of apnea or labored respiration. If the nurse notices that any of the parameters that they check, the Passero, the respiratory rate, the oxygenation, the adequacy of respiration, are not acceptable, they should let us know immediately and begin one-to-one nurse monitoring. The patient should be placed on a pulse oximetry and if available, a CO2 monitor. Here are some additional safety steps in the process. Dilaudid will have limits on the initial and each subsequent dosing. So the first dose of Dilaudid, it will be 0.5 milligrams or less, and the maximum single dose will be 1 milligram. No benzodiazepines or muscle relaxers should be given with opioids. No IV phenergan with any opioids. No fentanyl patches placed in the ED since their maximum onset isn't for 12 to 24 hours. And the nurses should notify us of any unacceptable findings on the assessment. And if they need supplemental oxygen, they should be placed on CO2 monitoring if it's available in the ED. And as part of this project, we're getting CO2 monitors for all the EDs. Additionally, as part of this process, we're asking physicians to use lower doses or non-opiate alternatives and avoid Dilaudid in patients that screen high risk for opiate-induced sedation. Additionally, U.S. Acute Care Solutions has a narcotic usage guideline, which gives some guidance on opiate usage and some recommendations for non-opiate alternatives. Additionally, the USAC's guideline recommends not using IV hydromorphone, which I support since most of the serious events that we have been related to hydromorphone. And it's part of the reason we have reduced dosing for hydromorphone in our recommendations. So here are the U.S. Acute Care Abdominal Pain Guideline recommendations for non-opiate, and they include ketorolac and ketamine. Here are the USAC's recommendations for back pain. Again, we see ketorolac at 10 to 15 milligram dosing, or Motrin, 400 milligrams. And then the subdissociative ketamine or IV lidocaine. Here are some of the USAC's recommendations for headache management, including IV meclopramide, IV compazine or prochlorperazine, Imitrex, or ketorolac. You'll notice that the USAC's guidelines for Toradol and for ibuprofen are 10 milligrams to 15 milligrams for ketorolac and 400 milligrams for ibuprofen. Ketorolac recommendation is based on this study, which compared various doses of ketorolac and found that the analgesic ceiling was 10 milligrams for ketorolac. Likewise, the analgesic ceiling effect of ibuprofen has been shown in several studies to be around 400 milligrams, with no increase in analgesic effect above this, but with increased side effects. So what about subdissociative ketamine for alternatives to opiates and in patients that are high risk for opiate sedation? This is well established as a safe treatment for analgesia in the emergency department. The problem is the Texas Nursing Board has a policy statement saying that ketamine in any form is outside the scope of practice for RNs unless they are under certain specific circumstances. Those specific circumstances basically have an anesthesiologist, an emergency physician, or a CRNA in the room with the nurse while they're administering the medicine, or in an intubated patient. Fortunately, the nursing board has given additional guidance about what they call off-label ketamine dose, which means the subdissociative ketamine dose. That it can be allowed if there's a facility policy supporting it, that the nurse has specific competencies for it, and that there are distinct separation between the anesthetic and the analgesic doses are established, and that we show that there's literature supporting its use. Many of us have already been using ketamine for analgesia in high-risk patients. However, I'm asking and the hospital's asking that we hold off on that until we develop a policy and train the nurses in using this subdissociative ketamine. So as part of this opiate monitoring policy, we are working on this, and we'll get this through as soon as we can. But until that time, please refrain from using ketamine in a subdissociative dose unless you will be in the room giving the medication. To finish, let's go over a few key items of this. Each patient that receives parenteral opiates will have a risk assessment completed prior to opiates. The monitoring assessment will be done at 30 minutes and at discharge or transition of care from morphine. Hydromorphone will have an assessment at 30 minutes and 60 minutes and at discharge. Now, for transition of care, if the patient's admitted to the hospital, the 60-minute hydromorphone can be done on the floor if the 30-minute assessment is acceptable. Fentanyl will be done at 5 minutes and at discharge. Additional safety steps, Dilaudid will be limited to a maximum initial dose of 0.5 milligrams and a maximum single limit of 1 milligram. As a note, USACS recommends not using Dilaudid at all. No benzodiazepines or muscle relaxers will be administered with parenteral opioids. No IV Phenergan with parenteral opioids. No fentanyl patches administered in the ED. And the nurses will be empowered to stop the line for violations of this. Thank you for your attention and time listening to this. We appreciate any feedback you have as we go through this process, and we're hopeful that this will provide safer care for our patients receiving opiates in the ED. Thanks again.